Good morning, everyone. Welcome to today's webinar hosted by the American Academy of Pediatrics and healthychildren.org. Today we're discussing RSV, which is the #1 cause of hospitalization in infants under the age of 1. Today we'll be updating guidance on the symptoms, diagnosis, treatment, and management of RSV, as well as the latest CDC recommendation for a new prevention strategy that works like a vaccine to help reduce serious illness from RSV. But before we begin, a few housekeeping items. This webinar is being recorded, so if you lose connectivity for any reason, you will be able to watch and listen to the archived webinar, which should be posted to the website in a few days. If we can help you with any technical issues during the webinar, please use the chat function to send us a message. We will have time at the end of the webinar for questions and answer session. To ask a question, please use the chat function. You can activate chat by clicking on the speech bubble at the bottom center of your screen or the person-shaped icon for mobile users. You can send in your questions at any time, and we'll get to as many as we can at the end of the presentation. Let me introduce our host, Dr. Jennifer Shu. Dr. Shu is a practicing pediatrician, author, and mom in Atlanta. She is the co-author of Heading Home with Your Newborn and Food Fights, a frequent guest on national and local television, radio, and web-based programs. She's also served as the Living Well health expert for CNN.com, has contributed medical information to Baby Center and WebMD, and serves on the Parents Magazine advisory board. And finally, she is the medical editor of healthychildren.org, the official parenting website of the AAP. Dr. Shu, good morning.
Good morning. Thank you so much for having us today. We are already seeing an uptake of RSV cases in the United States, so much so that the CDC, or Centers for Disease Control and Prevention, has issued an advisory report recently. And today we have the pleasure of having Dr. Yvonne Maldonado come here and speak with us at our webinar. Dr. Maldonado is a pediatric infectious diseases epidemiologist and current acting chair of the Department of Medicine at Stanford University School of Medicine. She attended Stanford University School of Medicine, completed pediatric residency and pediatric infectious diseases fellowship at Johns Hopkins University, and was an epidemic intelligence service officer at the Centers for Disease Control and Prevention before joining the faculty at Stanford University. More recently, she has focused on health disparities and infectious disease outcomes, including COVID-19 in pediatric and adult populations. Welcome, Dr. Maldonado. So let's get to the first. Great to have you. Let's get right into it with the next slide. Can you tell us what exactly is RSV?
Well, RSV is a viral infection, as you've heard, which is one of the many viruses that cause cold-like and cold-like symptoms in children and adults all around the world. It is a virus that is transmitted from person to person, and it can enter the body through the nose or eyes, usually from contact with saliva, mucus, or nasal discharge. Now, this particular cold-like virus is much more important than many people realize, because although it seems to start off with very much of the same symptoms as other cold virus-like viruses, this particular virus is extremely contagious, and by the age of 2, virtually every child has had this infection. And out of 100 children who get it, about 20 will wind up with lower respiratory tract infection that might lead to either a hospital, a doctor visit, a healthcare visit, a child visit, or a hospitalization. And about 2 to 3% of children who get this virus, even healthy children, can wind up in the hospital. Now, as you mentioned earlier, the timing of this virus is usually very stereotypical. It usually occurs in the late fall through early spring months, although it does vary in some parts of the country and especially in some tropical climates around the world. It is, as I said, a very common cause. of hospitalization and is thought to be the most common cause of hospitalization in children under 1, including children outside the United States. So it's quite an important virus, and it's very hard, unless you do a diagnostic test, to really distinguish this from any of the other cold viruses when your child first gets sick with it.
Thank you. So next slide, you touched a little bit about it being contagious and transmitted by respiratory droplets and direct contact. So, so other than the usual hand washing, you know, these babies often aren't old enough to wear masks. How else might these things be transmitted, the virus?
Well, yes, in the hospital in particular, we're extremely careful about allowing children and adults into the hospital setting if they have respiratory symptoms at any time of the year, but especially during the fall and winter season because of the risk for RSV in particular being transmitted among hospitalized patients and staff and as well. And so generally, if somebody is sick, you might have respiratory symptoms, whatever the cause might be, you may want to make sure that that person is not around others, especially those who are vulnerable to having more severe symptoms. But an infected person will cough or sneeze and can pass the virus on through coughing or sneezing. You can also get the virus from droplets that might have spread to your hands or to surfaces that you've touched. And then if you touch your face or your nose, your mouth, your eyes, you can actually spread it that way as well. And so, especially with children who have a hard time controlling their secretions, it's a little bit harder to be around them. And obviously, you can't tell them to, keep their hands away from their face. So you have to be especially careful there. So sometimes children may, when you just touch their clothing or the bedding that they're in, for example, you may actually catch the virus from touching those surfaces that may be contaminated with secretions from children.
So we hear about measles being, transmissible within the air for many hours. Is it known how long RSV can stay, maybe in the air or on surfaces?
Well, RSV doesn't stay on surfaces for very long, but the issue is that the child may be coughing and sneezing, have a runny nose, so it's actually always present. And even if it's not us, it doesn't stay alive on surfaces for very long. If they're continuously having symptoms, that's a risk period for the surfaces around those children to be potentially contagious. But measles has a very different transmission mechanism. Measles is an aerosol virus, so basically those aerosols are very, very small, 5 microns or less in size. And so those can float around in the air like little dust motes for up to 2 hours. Whereas with RSV, it's really a droplet disease. It's not going to float in the air for very long. The bigger droplets are going to fall to the ground, fall to clothing, etc. And so it's not as contagious as measles, but still you might not be aware that you're being exposed by touching surfaces.
So in the hospital for RSV, is it recommended that healthcare providers wear mask, gown, gloves, any of that type of PPE?
Well, every hospital has its own infection control policies, but in general, it is true that when a child is known to have RSV infection and they're hospitalized, generally there will be a mask, gown, and gloves used around that child for the reason that I mentioned. Some places don't actually use the mask because it's unless you're, but again, that really varies from place to place. But in general, we do recommend that a mask, gown, and gloves be used in a room where a child has RSV. Now, the other difficult issue around hospitals, as I mentioned, is family members may come in. They may have respiratory symptoms. So it's very important for many hospitals, if not most, to screen when people are coming in for symptoms. And so we know that families are anxious to see their children in the hospital, but if they're not allowed in, they should understand that part of the reason is because they may actually transmit themselves to other vulnerable children or family members when they're entering the hospital.
Thank you for that. Let's move on to the next question. And can you talk about the age groups where we might see RSV and the complications of RSV infection?
Yeah, so as I mentioned, most people develop RSV infection in the first 2 years of life. We know that it's, as I mentioned, very, very easily transmitted. But unfortunately, this virus does not confer lifelong immunity. There are, by the way, two types, RSV type A and type B. And both of these act very similarly, but they don't provide cross protection. So if you get one strain, you're not immune to the other. And over the course of a year or so, you will lose immunity. So every age group is susceptible to infection. It's just that young children and adults over 60 are at highest risk for developing severe disease. And part of the reason for that is that the virus itself causes inflammation of the airways, especially the smaller airways that are deeper in the lung tissue. And babies have these very small airways. So if they're inflamed, it's very hard for them to get air back and forth in their lungs. And that's why they're at higher risk in general. And of course, children and adults who are immunocompromised, those who have chronic lung disease, are at higher risk for developing severe infection. There are also health disparities, which we can talk about later.
Okay, cool. Well, why don't we first talk about how to take care of a child with RSV, and then we'll get to that health disparities before the end of the presentation.
Right. Well, and so I know this may sound alarming for a lot of people to say, oh my gosh, this is a very common cause of hospitalization. But again, the highest risk children, as I mentioned, are those with underlying conditions, especially lung issues, premature babies who've required oxygen in the past, for example, etc. But most children, again, are going to get sick and don't wind up in the hospital. They may actually wind up being seen in an outpatient setting, for example. But most of the time, the vast majority of the time, you can manage this like you would with any other bad cold-like illness. In fact, you might not even know your child has RSV. You may just know that they have respiratory symptoms that seem like a cold. And so some of the things that people can do at home include using nasal saline with gentle suctioning of the nostrils just to pull out the mucus and allow the baby to breathe and feed more easily, because they may have a runny nose and it may be difficult for them to breathe and also to potentially to breastfeed or feed other ways. Cool mist humidifiers can help break up mucus as well. So those are really helpful also. Really making sure that your child takes fluids on a regular basis, staying hydrated, and with frequent feedings if that's necessary, if they're only able to take small amounts over a period of time. So infants with a common cold, including RSV, may feed more slowly, or they might not feel like feeding at all because of the breathing problems that they have. So trying to suction the baby's nose before attempting to breast or bottle feed may be helpful. And supplementation is unnecessary for breastfed babies. So if you're exclusively breastfeeding, you don't need to worry about additional supplementation. But however, there may be some issues with the baby trying to breastfeed, as I mentioned, just because of the breathing, the nasal congestion. So expressing breast milk into a cup or a bottle may sometimes be an option in that situation. And please remember that if an infant is older than 6 months of age, you may be able to use acetaminophen or ibuprofen to help with low-grade fevers if they occur. But please avoid aspirin and cough and over-the-counter cough and cold medication.
That's a good reminder about the over-the-counter stuff as well as aspirin. And I also noticed you don't mention antibiotics or antivirals. So yeah, it's a lot of comfort care. So let's talk about, is it possible to have more than one infection at a time in addition to RSV?
Oh, absolutely. And it's actually not uncommon for us to see that infants and children can have dual or multiple infections at the same time. These viruses travel around during the same season. There are many respiratory viruses. that occur during the fall and winter seasons. And as I mentioned before, for most of these, if the child is on an outpatient, is at home and doing well with the interventions that I mentioned, we might not ever know that the child has more than one infection because they all generally appear the same. For children with more severe symptoms, and where we've done studies for them coming to the emergency department, urgent care center, or hospitalization, when studies have been done looking at those children and using nasal swabs to diagnose the infection, we find that it can be quite common. For example, during COVID, we found that up to 20% of infants and children had COVID and flu at the same time, or COVID and other viral infections. So yes, we can see that. Now, we don't think that the disease may be more severe with more than one infection, but it just means that with all those viruses out there, it's more likely that your child will have some kind of a cold during this upcoming season.
Okay, so at what point might a parent or caregiver need to reach out to the pediatrician? What kind of symptoms?
That's a great question, and this is something that obviously all of us as parents, I have 3 adult children now, but I do recall wondering when I should call in or when I should consider bringing my child in. Really what you want to look at are symptoms of bronchiolitis, and bronchiolitis is really a small airway disease. It's really characterized by inflammation of the airway. So as the child is trying to breathe, you'll hear a little bit of a rattling sound or a wheezing sound, and grunting, as you see there in the diagram. You might see evidence of either fast breathing or indrawing of the chest wall. So you can see that particular symptom is actually more worrisome than just a little bit of wheezing. But any evidence that the child is really having trouble breathing by indrawing of the chest wall is concerning. Symptoms of dehydration, and one way that you can measure that is if your child has had fewer than one wet diaper every 8 hours or so. And of course, if the child has gray or blue discoloration of the tongue, lips, or skin, that is another sign. And for children with a variety of skin tones, you can always look at the lips to really be able to tell, or the nail beds in particular, if skin tone may be difficult to really tell some discoloration, but gray or blue. And then finally, significantly decreased activity and alertness. Now, it is true that children with colds can sometimes be less active than normal, but if you see really significantly decreased activity, especially if combined with some of the other symptoms, that's when you should call your provider's office.
Yeah, that's a great video because you can see the indrawing, as you were mentioning, the retractions even at the neck level, and there's kind of some head bobbing going on. So noise in and of itself, usually not so concerning as you mentioned about the wheezing, if the child is calmly breathing, but if they're also, huffing and puffing, panting, not a good sign. Okay, thank you. So we'll go on to the next slide, and that is, how is RSV diagnosed?
Yeah, so as I mentioned, RSV is generally very hard to distinguish from other viral infections during the respiratory virus season, because the symptoms are, I just talked about, a little bit of maybe, runny nose, cold-like symptoms, upper respiratory symptoms are generally across the board. Now, not all viruses actually have wheezing, although there are other viruses that can cause wheezing as well, but the one that we always think about is RSV. So that tends to be a hallmark, but it's not the only virus that can cause wheezing. So if your child is having any of the more severe symptoms that we just talked about, and you've brought your child into your provider's office or urgent care center or emergency department, they may do a nasal swab. That is, they'll take a swab and takes mucus samples from your child's nose to be able to identify whether there's an RSV or other virus there. That's usually a first start. Depending on how sick your child might be, they might have a chest x-ray And they also may have a little pulse oximeter, a little kind of like a giant paper clip, a giant clothespin type device, not harmful, it doesn't hurt, that is put on their finger or toe to measure oxygen levels in the blood, just to measure how well oxygen is getting into the lungs. But most children actually recover without any difficulties. I mentioned most children really are either not going to have to come in to their pediatrician, or will come in for a visit and will be able to go home with local care, as we talked about before. So that's why we generally don't test children if there's really not a particular, as we'll talk about, not a particular preventive treatment for it once the child is infected, and home care is generally advised.
Regarding the nasal swab test, is it only a nasopharyngeal swab, or are there any nasal, like front of the nose, or pharyngeal, like throat swab tests that can detect RSV?
Yeah, there are a variety of different methodologies. So in general, it will generally be a nasal swab, probably not the very deep ones that we saw during the pandemic, but some places may actually do those. It really depends on what test is available at each practice.
Okay, great. So let's move on. You kind of talked about some prevention measures, the normal hand washing, stay at home if you're sick, clean surfaces. What new prevention measures are available now?
Yes, well, I think this year we are really excited that there are two new opportunities to prevent RSV infection in young children, and actually also some opportunities for older adults as well. And these were just approved by the Food and Drug Administration and the CDC this year between May and September. So there's a lot of activity around prevention right now, and we are busy updating all of our pediatricians in the US about these opportunities. Now, the first one is an antibody. And I think many of you know that antibodies are proteins that are shaped like the letter Y, that actually can stick onto viruses and bacteria and other foreign objects in the blood, and other mucous surfaces in the body, and can help prevent, either kill those organisms or prevent them from infecting the child. So antibodies can be made naturally after infection, but the antibodies that we use are called nirsevimab. The new one is nirsevimab. It's a long name. Or the traditional one has been called palivizumab. And these are antibodies that are produced commercially in large quantities in a very safe method to target specific parts of the RSV virus. They function like a vaccine, but they aren't a vaccine themselves. They don't provide a longer lasting immunity because you're not developing the immunity yourself. You're being given the antibodies through a shot. And these actually are very effective, especially nirsevimab, the new agent that was just approved recently. This particular antibody is given in a shot, and actually only needs to be given once during the respiratory season to children, and it's recommended for children under 8 months of age in their first RSV season. And for children who are older, who are going through their second RSV season, it can be given to children between 8 and 24 months of age. And that's for specific children with especially higher risk of complications. Not to all children, but all children can have access to the nirsevimab antibody at 8 months and under during the RSV season. It's very effective in preventing not only RSV infection, but medically attended visits, that is visits to the pediatric office, to the emergency department, and especially for hospitalization. So this is a really exciting opportunity for us to prevent disease. As I mentioned, there is no treatment once a child gets infected. So it's really important to think about trying to get newborn children, young infants, this nirsevimab in their first RSV season.
So you mentioned during respiratory season, what months specifically would that be given?
So the nirsevimab is recommended to be given within a week of birth for children who are born during the RSV season. And I know this is a little complicated, so this is why we hope providers will bring that up with people who have newborn babies during the RSV season from October through March. Now, in some places, as I mentioned, RSV season might start earlier or it might last a little bit longer than March, but in general, October to March is the time period. Now, if a child is born in the off season, that is before October or after March, and they are still under 8 months of age, they can actually get the shot as well just before the RSV season. So, for example, if a child was born in April, May, June, July, August, September, they can still get the shot in October or through March, depending on their age. But it's recommended to be given, again, within a week of age of birth for children born between October and March, and starting in October if they were born earlier in the year.
So if we're trying to give it that young, is this going to be available in hospitals, at pediatricians' offices, pharmacies, health departments? Where do you think the distribution will be?
Well, so that's, I think, so again, with our excitement about this availability, because we have the opportunity here to really knock down not only RSV infection, but hospitalizations this season and going forward. The issue is that this product was really just recently approved by the FDA and the CDC. And so really the administration and the rollout to practices and to hospitals has just started in September. So we're only really a month into distribution of this particular product. And so not every hospital will have it and not every practice will have it. So it will be important to talk to your pediatrician if you're so that you can find out from them whether they will have it available, and if they don't have it, where they can advise you to actually get it. And it will be important for people who are expecting children to be born during this season to find out if the hospital will provide it as well, because it may be that the hospital will provide, for example, my hospital, we will be providing nirsevimab to all newborn babies. And we know that the administration this year will be a little more not routine yet because it's brand new, but we want to start as quickly as possible. Not all hospitals, however, will have that capacity. So there will be some education going on this year for families and providers to understand who will have it available and who might not.
Thank you. So our next slide has to do with, what can parents and caregivers do? How do we contain RSV, keep it from spreading within homes, schools, daycare settings?
Yeah. Well, as I mentioned, that's going to be almost impossible, unfortunately. I will give you some hints as to what can be done. But as I said, despite all our best efforts, because these viruses are so transmissible, almost 100% of children will have become infected by their second birthday. So we will do everything we can to prevent it, but it's not easy. And that is because it can be a very mild cold-like illness, and most people may not know they have it. And so they may transmit to others. So including parents and grandparents, they may not have symptoms. They may have incredibly mild symptoms relative to to babies. And so they may not realize that they may be carrying it. But some things you can do, as we talked about a little bit before, is to stay away from others if you have cold-like symptoms. And that's probably the best advice. Now, unfortunately, most people, as I mentioned, think they have allergies or think they have a very, very mild cold and will still go to work or to school or to other daycare settings. And so it's very hard to really enforce that. But if you are sick with a mild cold, please try to stay away, especially from people who are have underlying chronic conditions, immune suppression, or especially babies under a year of age. The other thing you mentioned is washing hands in between touching your face and hand before you touch your face and hands. And in some healthcare situations, for example, we are going to be, using masks. For example, our hospital in our county mandates mask use for all providers and individuals entering our hospital during the respiratory virus season because it is so difficult in other ways to prevent transmission. You can clean up around yourself, throw, wash clothes, etc., to keep the away from contact. But I wouldn't go to extreme lengths there because it's going to be very hard to constantly keep track of all the surfaces. But normal hygiene will be helpful in trying to reduce transmission.
So if a child is known to have RSV, how long do they need to definitely stay out of daycare?
Well, generally, the children will need to stay out until their symptoms are over, especially if they have a fever. And that can be quite challenging because children may have a runny nose for some period of time. So each daycare in each district will have rules about when the child can come back. But in general, when their symptoms are gone and they are no longer have a really runny nose and that can be controlled, then they can come back. But I would encourage you to check with your daycare to find out what their rules are about this. But fevers for sure children with fevers should not be coming into daycare.
Okay, thank you for that. So let's talk about some special populations that you mentioned are at higher risk for RSV infections and complications.
Yes, well, we know that children who are on Medicaid, and it's not the fact that they are on Medicaid, but in general, these are called health disparities, and by that we mean that there are social situations and environmental situations for some families based on their income and their ability to provide normal environmental protections that can put children at risk. So children on Medicaid in general may have less access to prevention. For example, they may be more likely to have parents who are frontline workers who may have to be facing individuals with a greater risk of getting infected themselves and bringing the virus home. So we know that children on Medicaid tend to have a higher risk because their family situation may lead them to be at higher risk for being exposed to the virus, not because they themselves have any other significant risk factors. We do know, however, that American Indian infants and Alaskan Native infants are at higher risk for RSV, probably for their own genetic reasons. They may be genetically more susceptible not only to getting infected, but to having more severe symptoms.
That's all excellent information. Thank you for that. We now have time to answer some of the questions that were both sent ahead by attendees as well as entered in the chat box during our presentation today. So thank you everyone who has submitted questions, and please keep going with that. Some of it has to do with the timing of the nirsevimab antibody treatment. Maybe you can answer these two questions together. So can this nirsevimab be given at the same time as routine childhood vaccines? And then let's say the child has already been diagnosed with RSV during that season. Does the nirsevimab need to be delayed for any period of time?
Yeah, so the really remarkable thing about nirsevimab is, first of all, the fact that it really does prevent more than 60% percent protection. That is 60% reduction in risk of actual infection, visits to the physician if a child does get infected because the symptoms are so mild, and importantly, prevents the symptoms from progressing if the child gets infected to requiring hospitalization. So this particular antibody preparation prevents infection, hospitalization, and other medically attended visits. Now, because it needs to be given, hopefully, to as many children 8 months of age and younger as possible, it has been studied and known that it will not interfere with other vaccines, so it can be given along with other vaccines of childhood. I'm sorry, what was because you asked me two questions. What was the other question?
If they had the RSV infection, do you need to wait to give the nirsevimab?
So you should, if the child is actively infected with RSV, it shouldn't be given right at that moment. Hopefully that won't be the case because we want to give the preventive treatment before the season even starts. But if unfortunately the child did not get nirsevimab before the season starts, that is usually between October and March, or if the child was in an area where the season started earlier, you should just wait until they get over their symptoms. But it's still recommended that the child get a treatment because we don't really know how much immunity that infection might provide relative to the immunity of the nirsevimab treatment.
So talking about immunity, can you talk a little bit about when pregnant women get the vaccine and breastfeeding women, what's their protection for the child?
Yeah, so the other really remarkable opportunity we have now, we didn't get a chance to talk about this during the session, is that there's also a vaccine available. So remember, we're talking about nirsevimab is an antibody preparation. So this is not a vaccine; it's a pre-made antibody preparation that prevents disease. The vaccine, there is a vaccine available now, and this particular vaccine is given to pregnant women between 32 and 36 weeks gestation. And this vaccine is given to the pregnant woman so that she can make antibodies, and those antibodies can then be transmitted to the fetus before the fetus is born. And those antibodies will protect the baby during the first 6 months of life. And again, this vaccine is incredibly effective at preventing A, infection, B, medically attended visits if the baby gets infected, and hospitalizations, again, if the baby gets infected. So we know that it is remarkably effective, probably as effective as nirsevimab. So this year as well, parents will have a choice whether to vaccinate the pregnant mother between 32 and 36 weeks with one dose of this vaccine, or for the baby to get the nirsevimab injection within 1 week of birth during the RSV season. And so these are the choices that parents will be facing this year, but they're very happy choices, I would say, because it means that you have an opportunity, two different kinds of opportunities to prevent infection in your baby this year, because we know the season is already here. It started early in the south of the US, and it's definitely going to keep going this year. And we have this opportunity to really prevent disease in infants who are at high risk for being hospitalized and having symptoms that may lead to longer term issues. So again, if a pregnant person is going to be delivering soon, I think they should talk to their provider. The vaccine should be given to a pregnant person between 32 and 36 weeks, as I said, but between September and April, so that they can deliver and have the antibody in their baby's system to protect them during the upcoming RSV season. Now, regarding breastfeeding, there are many studies that go back decades looking at whether breastfeeding protects against a lot of different things: diarrheal disease, pneumonia from a variety of causes, and of course against RSV. And there are data that suggest that breastfeeding is protective against RSV infection and other infections, but that is not enough to protect against this virus all by itself. So I would say breastfeeding is helpful, but either the vaccine to the pregnant woman or nirsevimab to the baby are really going to be highly effective, so that they can be done. Obviously, we always try to recommend breastfeeding when possible for babies because of the wonderful nutritional, immunologic effects and the prevention of a number of diseases. But it's not sufficient.
That's very helpful. So just to clarify, we could envision a pregnant person getting the vaccine as well as the baby getting nirsevimab. Is that correct? It's not necessarily one or the other? Or?
Yeah, so in general, and this will be, again, this is a remarkable opportunity. We have two choices. We have a vaccine or we have nirsevimab, but we're still working through all these two new opportunities. It's probably not necessary for most babies to have both. So that is, you probably don't need the pregnant person to get the vaccine and the baby to have nirsevimab. There may be cases where that's that may be needed or useful. And that's where you should all talk to your providers about this, or look to the CDC for guidance. But in general, one or the other should be sufficient to protect the baby. And remember, the reason the antibody and the vaccine are given so in this way is because the vast majority of infections that lead to hospitalizations and hospital and doctor visits occur in the first 6 months of age. And it's really hard to vaccinate children with true vaccines early enough to get them to develop immunity in those first 3 to 6 months of age. So giving the mother the vaccine or giving the baby antibodies directly at birth is the best way to protect those very young babies before they have an opportunity to be exposed to the virus.
Okay, so there is a small population of infants who are eligible for a different type of antibody treatment called palivizumab. Would that be the same as if the mother got the vaccine, then they no longer need the palivizumab, or is this a different scenario? How does palivizumab differ from nirsevimab is what some people are asking.
Yeah, so palivizumab is a very similar, although palivizumab and nirsevimab is much, much more effective at preventing RSV infection than palivizumab is. However, palivizumab is still available at this time for use in children with very specific conditions. That is, children who were born at 29 weeks gestation or younger, and who had chronic lung disease or chronic heart disease and other conditions, which will need to be reviewed by their provider. So palivizumab does not work as well, and it also doesn't work as well in older children, which is why it's not recommended by the American Academy of Pediatrics for use in children over 29 weeks gestation. The other thing is that palivizumab is not a long-lasting antibody. I failed to mention that. Nirsevimab is one shot, and the way it was prepared, it lasts in the baby's body in the circulation for as we think probably longer than 5 to 6 months, but we know that it protects for up to 6 months or so. And whereas so that's really remarkable that one shot can protect for up to 6 months. However, palivizumab does not have that capability, and it deteriorates after about a month. So you need to get up to 5 shots of palivizumab during the RSV season if your baby is one of those children who is 29 weeks or under gestation and has underlying conditions as well, or has underlying conditions. And so because of that, palivizumab is not preferred for every baby. It's only for very specific situations. If you've already gotten palivizumab, but you haven't finished your 5 doses, you can just get nirsevimab instead, and you don't need to finish the palivizumab doses.
Wow, so lots and lots of details that each person's pediatrician hopefully will be able to help answer. And for the recording of this webinar, the AAP staff will put some of the details about the different antibody treatments as well as a vaccine regarding RSV, because I know this is a lot to digest. So thank you so much for that. I would love to turn things over now to the AAP to kind of wrap things up for us.
Thank you so much, Dr. Hsu and Dr. Maldonado. We appreciate you. We want to remind participants to register on healthychildren.org to receive our e-newsletter, a personalized homepage, and special offers. And don't forget to follow healthychildren.org on Instagram, Facebook, Pinterest, and Twitter. We hope you enjoyed today's webinar. Keep an eye out for a quick survey and let us know what you found most helpful and any suggestions you may have. And a very special thanks to our sponsor, Sanofi. Thanks again for joining us.